Okay, good morning, everyone. Welcome to this TIPS Development Dialogue, where we're looking at the socio-economic realities of localizing pharmaceutical production in South Africa. It's been a topic that's been discussed for, I think, quite a few years, but became quite prominent during the COVID pandemic, where we hit some very real challenges in this country, and it brought to the fore what are we doing in the sector? We've got capacity, but we're not quite achieving some of the objectives that we had set out. And it prompted a rethink and a fair amount of research. So TIPS has embarked on a process of doing some of that research, and there were a few other players. We wanted to have a conversation today, presenting some of our research, but also discussing some of the key issues. We've got a number of panelists, speakers and presenters. So on our agenda today, we're going to have Swasti Sumaru from the DTIC saying a few words of welcome. And then we'll have presentations from Dr. Niva Machetla, Sakile Ndlovu and Annie Parsons, who've worked on the TIPS research. And then we'll have discussants, someone from private sector, from CIPLA, Paul Miller, and Marion Skonfeld from the National Department of Health, who will then give their insights on these issues. We'll then open up for questions and discussions and insights from the audience. And often what I say at these events is a lot of expertise, both in the room and in the virtual room, who can bring their knowledge to this topic. So it's a dialogue. It's not an opportunity for us to just, talk about the research, but it's a conversation that we need to have around some of the key issues. So we are looking at insights from the participants and those in the virtual room and in the room. So people online, use the chat box as well to give your comments and your thoughts as well, and then we can open up for questions after the presentations and discussants. Now, let me move across to Swasti for a short welcome from the DTIC. Thanks, Swasti.
Thanks, Saul. Morning, everyone. My apology, I could not join in person, but good morning to everyone, and thank you for joining us. I think from the DTIC, really, it is a pleasure to welcome you today to this development dialogue on the socio-economic realities of localizing pharmaceutical production. And without, at the risk of repeating what Saul has said, I think largely over the past few years, few issues have really attracted as much attention in health and industrial policy as the discussion around pharmaceutical and vaccine manufacturing in Africa. And again, at the risk of belaboring this point, I think it's still worth mentioning and reflecting on some of the lessons of COVID-19 while they remain relatively fresh in our collective memory. As we are aware, the pandemic exposed many weaknesses in the global supply chains and highlighted the risk associated with Africa's heavy dependence on imported pharmaceuticals. It also prompted important lessons and questions about health security, access to medical countermeasures, and what it will take to build greater resilience across the continent in the years ahead. Here in South Africa, we found ourselves at the center of this conversation. The country has, as you know, has some of the strongest pharmaceutical capabilities on the continent, a quite well-established regulatory system, recognized research institutions, and a growing ambition to strengthen local manufacturing. And I think as Saul has indicated, we've been talking about this for many years now. But at the same time, we face difficult realities. Building sustainable local capacity requires, I guess, more than just conversation and good intentions. What is required is really, clarity, certainty, viable markets, well-established regulatory capability, and for us as a country to move to ML3 for medicines and for achieving WHO listed authority status, we do require ourselves to participate in regional collaboration and develop regional value chains. And I think most importantly is consensus and policy coherence across government. So you may or may not be aware, these considerations and many of these pillars have become central to us developing the pharmaceuticals manufacturing roadmap, which is currently being done jointly by government and its partners. In fact, last week we presented to the presidency our thoughts and sort of a draft roadmap. It was quite well received. The roadmap really seeks to build a future-ready, innovation-led and resilient pharmaceutical value chain that is self-reliant, export-oriented and globally competitive. Sorry, that was me just reading out our vision for the roadmap. It is aligned to the AU target of achieving 60% of local manufacturing of pharmaceutical products and vaccines on the continent by 2040. Our target is achieving 50% of the local market and 10% of the African market by 2040. And the roadmap recognizes that pharmaceutical manufacturing is not just a health security imperative, but it also presents an opportunity to drive industrialization, innovation, investment, and skills development. Today's discussion is therefore timely and important. It asks us to move beyond the simple question of whether a localization is just desirable and instead consider what is economically feasible, socially beneficial, and what is required to ensure both health security and sustainable industrial development. As I said, the conversation also comes at a critical moment for the continent. The African Union has set ambitious targets for us to increase local pharmaceutical and vaccine production. But achieving these goals will require difficult choices about where countries must invest, how markets are coordinated, and how we balance affordability, resilience, innovation, and competitiveness. We are fortunate to have with us an exceptional panel representing research, government, industry, and health policy. Their perspectives will help us unpack both the opportunities and trade-offs involved in building a stronger pharmaceutical manufacturing base in South Africa and across Africa. And our objective today is not necessarily to reach consensus. We are here to deepen our understanding of the choices, constraints, and opportunities that will shape the future of pharmaceutical manufacturing on the continent, and I think to make good choices around industrial development without impacting security of supply and access. I'd like to thank TIPS, the researchers involved in this important body of work, and all of the participants for joining us today. And I do look forward to a robust and insightful discussion. And sorry, before I stop, just I want to reflect on something that happened during the pandemic as we engage in this discussion. So during the heart of the pandemic, it was either 2020 or 2021, where India had banned exports of its pharmaceutical products, particularly paracetamol and paracetamol-containing products. We no longer as a country manufacture paracetamol, the API, that has stopped many years ago. But at the time, it was one of the basic things that were needed to, treat infection, sorry, not treat infection, but to manage some of the symptoms around COVID. And we could not get access to basic something as paracetamol, which is like a 2 or 3 step manufacturing process. And as the DTIC, at the request of Department of Health, and Khadija is largely aware of this as well. So we had to make representation. Minister Patel, who was the minister of the DTIC at the time, had to write to his counterpart in India to allow, to relieve some of the ban on the export to South Africa particularly, so that we could get access to paracetamol. Now, this is probably one of the cheapest products you can get, but South Africa at the time were the mercy of India. And I think it's something that we need to keep at the back of our mind as we have these discussions. What does it mean when we don't have access? What do we need to ensure for pandemic preparedness? How do we ensure that, that we keep some of the some of the capacity reserved for us to respond adequately when we do need to. I'm going to leave you there, Saul. Thank you.
Thanks very much, Swasti. I don't know if we should clap at this stage, but we can. Thank you very much for your opening remarks and setting the scene for, I think, what we've been doing in terms of the research, but also some of the very real challenges that the researchers will talk in more detail around, and just thinking through where does all of this go. So we've got to use the phrase, we've got a lot of the ingredients to make this work as a sector. We've got capacity, we've got potential markets, there's demand domestically, there's demand globally, but or particularly in other African countries. But there's also cost drivers that come into all of this. And there's also disruptions to global supply chains, as Swasti has mentioned, by big events that give us a bit of pause for thought around how does all of this work. So lots of different drivers that influence our thinking, and we now going to hear from the team on how they've thought about these issues and how it will come together in terms of some of the next steps that we need to look at. So we're going to start off with Dr. Nima Makhetla, who's going to do the first input, and then we'll move to Sakile and Annie. So Neva is going to talk to the socio-economic effects of localizing parts of the pharmaceutical industry, and Neva is a senior economist at TIPS. Her bio is on the event flyer that we circulated. Neva?
So yeah, so we did a paper that tries to look at the pharmaceuticals landscape in South Africa. And it's really saying that, in effect, there's two factors we need to think about more carefully when we talk about localization. One is that, on the one hand, the obvious thing, which is that the vast majority, I mean, estimates vary, but around 2/3 of medications are imported in South Africa. And in fact, imports have been growing rather faster than exports until 2020, at which point the trends reversed. No? And this is in constant rand terms, depreciated with CPI. So imports have fallen back to 2015 levels, but that's still quite high compared to exports. Exports have increased by 65%, but they're still very small compared to our imports. And generally, it looks like a lot on the graph, but in fact, our imports are 2% of total imports, and our exports are 0.5% of exports are pharmaceutical, are medicines and vaccines. Just to be clear, pharmaceuticals, in theory, exports, we should also count things like dressings and other cloth, basically anything you use in medicine, but this is just medicines. Next slide. But at the same time, when we talk about localization, we're normally not talking about the private sector, we're talking about the public sector, and the public sector healthcare budget has declined in constant rand terms significantly. I mean, obviously peaked during the pandemic, but even compared to 2019, it's now lower than in 2019. And of course, the population is growing about 1.4% a year. So in per capita terms, it's falling even sharper. And the main threat to security of access to healthcare remains very low incomes for the majority of the population. Around 15% or so can afford health insurance. Everybody else relies primarily on out-of-pocket or the public health system, primarily the public health system. And in that context, limited budgets mean that sometimes you just can't afford as much healthcare as we think we should provide. And to be clear, there is a constitutional mandate to provide healthcare, so it's considered quite a serious thing. And it's important to flag that because people often say, oh, we have to worry, like Saul said about COVID-19, disruptions to international supply chains physically can lead to a disruption in supply, but actually the main reason people can't get the medicines they need is that they can't afford them, and government can't afford them either. And that makes it very hard to say localization, if it becomes at all more expensive than imports, is extremely hard to pursue. And the one thing I want to flag even about COVID was, we can argue about, was it a physical disruption to supply? There were some issues with PPE, but even at the height of the PPE, of the pandemic and the shortage of PPE, we were exporting PPE. Because why? We can't afford to pay as much as some of our foreign partners. And that certainly happened with vaccines. We produce vaccines for export. No? And I'm quite sure if we could afford to pay as much as people were paying in the US, more of those vaccines would have landed in South Africa. No? So I think we have to really think through the narrative about what causes the insecurity of healthcare in South Africa. And it's not really about local production as much as it is about affordability. Generally, though, just to be clear, when we talk about localization, focusing on the public sector, the bulk of medicines by value are sold in the private sector, and that also accounts for the vast majority of imports. And even by volume, the public sector is about a third of the total, but most medicines that are sold are still in the private sector by volume. Next slide. So if we look at our pharmaceuticals industry, as Swasti and Sol were saying, it's small, but it's strong. It's compared to most other, even upper middle income countries. What we cannot compare to is China and India and the global north, where you have much, much, much bigger, what I'm calling medico-industrial complexes. And that's important in terms of what do we see as a viable end state. So pharmaceutical as an industry, it's technologically advanced, but it's small and it's capital intensive. Those things do tend to go together. It has shown faster growth. Again, the experts have done very well. And it's got more advanced technology than most other industries, but it only contributes around 0.2%, that is 0.2% of national value added, that is of the GDP, and it generates around 25,000 jobs. It's a hard sector to study because it's not at SIC 3 level, it's at SIC 4 level, and the data is all at SIC 3 level, if you see what I mean. So it's hard to, the data tend to be, all of these data are contested to some extent, but the order of magnitude is correct. The strengths that we have, and the paper goes into this in great detail. We're very strong in fill and finish, that is formulation, packaging, taking the basic raw materials of medicine and making them into something you can actually consume. We have quite a strong research and skills base, especially for HIV and TB, because those are areas where we have special needs as a country, and in clinical trials. And we do have some very sophisticated and well-established local companies that have their own brands, and also some that do just contract manufacturing, which is a big thing in manufacturing generally, but specifically in pharmaceuticals, you contract to manufacture for the branded companies. Yeah? And it's an area of growth, I think, in pharmaceuticals generally. Our weaknesses are, and some of these we can debate to what extent these are actual weaknesses. Most drugs, substances, that is, APIs, are imported, although Aspen actually is one of the largest generic producers of APIs in the world, but in the world is the key thing there because they produce it mostly in Europe, not here. No? We often have local innovations that end up being manufactured overseas because we just don't have the depth and the capital markets to produce them here. There's limited effective demand, as we said, mostly due to low incomes across Africa, with small public budgets, and in the rest of Africa, often very dependent on foreign funding. And the demand regionally is fragmented between national authorities in terms of regulation and procurement. And of course, South Africa's own population, like we said, the public budget is declining and our population is small. We have 60 million people compared to well over 1 billion in China and India each, which means that if we don't have the continental demand, it's very hard for us to get up to the scale of demand that we need to grow. Or we have to do what Aspen's done, which is basically export to Europe. No? I think it's important to think again about where this all fits into the international value chain. We are a bit strong. I say we look like virtually every country in the global south. Actually, we're obviously stronger than many. But if you exclude India and China, but we don't produce basic drug materials. And as I'll get to, there's a debate about how we think about that. And that really reflects the size of our domestic and regional market and our latecomer status. So in other words, China and India, when they got into the business of pharmaceuticals, were competing with Europe and the US, where costs are higher. And they had a very big domestic base. We're competing now with China and India that have very low costs, are already up to scale, and have much bigger populations. Next slide. So, we did some modeling. Thank you, Randani. We had people did a very good modeling job, which you will see when the paper gets published. And what it found, to summarize, it was standard input-output type model. There was a lower multiplier for growth and employment than for the rest of manufacturing, which makes sense for a capital-intensive, skills-intensive, knowledge-intensive industry. In other words, for every rand you invest in, for every rand that you grow sales in pharmaceuticals, the impact on employment and GDP is actually less than for the rest of manufacturing. But I think what was particularly interesting was that if you increase exports, value added grows faster than if you just localize inputs. So of course, easy to say in a model, that just illustrates, it doesn't say if it's possible. But that was what the model showed. Next slide. Okay, so what I would argue in terms of the policy development process is that there's a problem which we keep, what Saul was saying, we keep going, we've been talking about this for at least 15 years. Well, really since HIV became like a very big issue at the WTO. But what we've seen is that we tend to deadlock over the strategic issues, even though there's kind of broad agreement on what we need to do practically. And what I would argue is the deadlock on the strategy has tended to get in the way of agreeing on what to do next in more practical terms. Next slide. So the strategic deadlocks are, firstly, how do we achieve economies of scale? So, pharmaceuticals, because it's advanced, you have high, you need big upfront investments. If you don't get up to scale, your cost per dose will be too high and you just can't compete. And we've kind of had this fight about localization without actually saying, but are there ways we could expand exports instead? And I mean, I think in practice, what you can see is that the companies that have exported are the ones that are growing most rapidly. No? Now, admittedly, there's a risk because exports can lead to overseas production too. No? But the fact is that's where we've seen the growth in recent years. Second debate is about how do we incentivize increased production? And I would argue the problem here is actually more that we keep talking about it in the abstract, but we don't have costing, which means we never get to the point of saying, well, what is the best option in terms of the costs and benefits and the risks for the fiscus? So the options people are looking at tax incentive for exports, where the Treasury basically ends up paying through reduced revenues, a direct incentive for new production, that puts the cost on the DTIC budget, or local procurement and offtake guarantees, which puts the cost onto the departments of health. And the fact is, though, that discussion needs to be, in my opinion, we can go around and around about who should pay, but if we don't know how much it will cost, we're not going to have a very useful discussion. And then finally, there's the question of should we actually focus on APIs? So a huge amount of the discussion has been about how do we get to produce these basic building blocks of medicines as opposed to how do we just expand sales by the industry and meet South African health needs better? So like we said, we have very strong fill and finish, but we have some API production, but it's small and it's almost entirely export oriented. If you cut out like the cannabis, right? There's a whole bunch that just do cannabinoids. But for the actual APIs for medicine as normally understood, they're virtually all exported. No? The unit cost is about 50-50 for generics. In other words, half the cost, I mean, it varies tremendously across the industry and by the kind of medicine, but around half of the value added is from fill and finish and half from APIs. Both phases can be technologically advanced because fill and finish can mean everything from putting it into a box to actually doing the formulation from basic chemicals. We have a lot of that basic formulation going on. And in practice, China, India, and the global north account for almost all API production. So we have some, but it's tiny compared to them. No? So the debate has been really, should we focus on getting API production going? And to be clear, we've had two big failed projects to produce API. One was Kitlapella, and the other one was the production of one of the vaccines, the pneumococcal vaccine. And I think we should be saying, do we understand why they failed? Before we act like the only way to understand progress in the industry is growth in API production. To be honest, there's no other industry where we say it's only moving into more high-tech production of inputs that counts. Now, normally we say, are you creating more jobs? Are you meeting needs affordably? Are you growing output? Next slide. Okay, so what are the practical measures where I think there is actually a degree of agreement, but we need to really think through what are the next steps for each. So one is we clearly do need an export strategy. that the nature of the demand for Africa is, firstly, every country has its own procurement process. There are some pooled procurement things that South Africa does not belong to, but also it's heavily funded by donors. So when BioVac is talking about exporting vaccines, they can do that because they're getting a subsidy from donors through Gavi primarily, and to some extent UNICEF. So how do we think about leveraging those subsidies, which are significantly bigger than we're going to get from the budget? I think we should also say, what would be a strategic approach to other markets? Like, we do export to Europe and other countries. How do we think about that? How do we build on that? And then also, finally, of course, what would be the supply side measures, which could include some incentives, particularly export incentives, obviously. There's a proposal to set up a SEZ at Gqeberha, where there's a lot of pharmaceuticals manufacturing coming online through Aspen. But obviously also, do we understand what are the infrastructure needs? Because that's becoming an increasing constraint on growth in manufacturing, as well as skills. No? Second thing would be, could we please cost the incentives that are being proposed? So there are proposals on the table for incentives. If we had a costing for them, I think it would be easier to have a serious discussion about whether they should, whether Treasury will support them and whose budget should carry them. I think it would be useful to have a more consistent platform to engage with manufacturers. We'd have to agree on the aims and the scope. I mean, the master plans provided a good example of this kind of platform, but also where they can go wrong. I think we should learn from that. One of the key issues, in my opinion, is government needs to have a mandating system where when businesses raise concerns, they get a response in a reasonable period of time, which applies to all of government. No? I would argue we need benchmarks for technology transfers. This is not to say government oversees technology transfers, but a lot of big failures in recent years are because people paid too much for the technology and the product turned out to be unaffordable. And so if government could at least assist by saying, here is a model, like when you run your mortgage through the bank model on the web, something like that would say this would be affordable. This particular technology transfer is not going to be viable without a subsidy. And how do we think about that? Obviously, we need to increase skills. The key constraints are, firstly, unequal education. So we have very high level education, but very few people make it through to the tertiary level. There's the brain drain because all of our people are trained to standards that they can get a job elsewhere often. And finally, there are limits on in-migration, and particularly in the healthcare system. They are explicitly designed to say local professionals should be able to veto immigrants so as to maintain their own pay. And one of the results is that of all these factors is South Africa has the highest gap in the world between professional and less skilled pay. And this is the point. If you want to deal with the skills pool, it will bring down pay for local people. We need to think about what that means. There are some government bottlenecks, and I would argue this should be as a minimum program. Everybody agrees about these things. SOPRA turnaround times is long. So SOPRA has to license new medicines and ongoing production, and its turnaround times are long. And they say because they don't have the budget to speed up, because it's a highly skilled process. So they should have a budget to increase their capacity. We also, when people do make local production commitments, we have no way of auditing them. So we need to think about who would carry out those audits, what would they look like? And then finally, the departments of health, particularly the national department, but also the provincial departments, their burdens have been expanding as the technology improves. And in the case of the national department, they've been doing transversal tenders, which means they tender for all the provinces at once, but they haven't actually increased their budget for that purpose or their skills and capacity. And so if they could get more resources there, that would probably also help. Next slide. And then the other thing is around local procurement and how we think about that by the public sector. The departments involved, there are many departments involved, but mostly it's the departments of health, the DTIC, the DSTI, and the Treasury. And they have divergent mandates. And one of the problems is you say to the Department of Health, you must pay for industrial policy through localization. This is not something they can do, even if they wanted to. It is not their mandate. So you either have to change their mandate or you have to accept that the industrialization costs have to fall on the DTIC or maybe the DTIC, or if it's tax incentives on Treasury. But shouting at them doesn't actually help. And honestly, we have seen individual officials being harassed about this in ways that are unproductive. But also it would help if there was a regular platform to engage on how do we think about using the national budget, in effect, to promote industrialization in pharma, given that the top mandate has to be optimizing healthcare outcomes for political reasons as well as social ones. But also we want to promote local production and also improve communication with local companies, because it doesn't help for the departments that care about industrial policy to promise localization, and then the Department of Health says we can't afford it. And the companies in some cases already invested to produce what they thought would be protective for local producers. Yeah? So that communication issue becomes important. Or like when the Department of Health changes standards, the local producers need to know in advance. And then again, I would argue you need to think through who's going to be the secretariat to convene the thing and make sure the research happens and all of that. The second thing is to, again, clarify the budget burdens. Who will cover what? And I would argue there has to be a red line that says, if it's a cost for industrialization, it has to be costed. You can't just assume the Department of Health will manage it. They have a very big budget, but they also face extremely big demands. Local production commitments, part of the problem is people say they'll produce locally and then they don't. And we know what happened with Transnet, where it almost drove them into bankruptcy, So there has to be some way of saying, if you commit to local procurement, there has to be a plan, it has to be auditable, and then we need a system to audit it. Now, that would only apply to new tenders, but at least we could start thinking about that going forward. There's a thing about the trade-offs between Black ownership in particular and industrialization, which is a lot of manufacturing companies established, they've been around for a while, their BE scores are not great. A new company that is importing, it's easier for them to get a higher BE score, but obviously they're just importing. So we've had this fight going on forever about how to manage that. Apparently, in the current Department of Health tenders, BE gets more points than local production. Is that a policy decision? Does it make sense? Finally, we should also say local producers should be able to match the cost of the least bid, but there's a problem there, which is because the unit cost depends on scale, it needs to be linked to offtake agreements as well. And that's difficult. So this would require a lot of thinking and probably regulatory changes, because under current tender rules, you really can't do it easily. And then finally, there's the issue about provincial, I'm sure you are surprised to hear, provincial departments do not always pay on time. And so we should try and find a way to deal with that. But obviously part of the problem is Treasury has been, people say, why don't they just use the conditional grants as a threat? But obviously you can't jeopardize people's health care to ensure payment on time. So you really need to think more about what are the systems that would ensure prompt payment than trying to use, actual sanctions. And that is a quandary. Next slide. So what I would argue is we need to really focus on the practical measures and stop shouting at each other about things that are pie in the sky or quite abstract. And if we get the practical measures right, I suspect those other discussions will become easier. And I think we do need, a task team of the departments that works together to come up with proposals, rather than each department comes up with proposals or decisions and takes them to cabinet and thinks they'll be binding because they get, they're not, in effect. And that would, again, give us a framework to talk about the strategic issues more productively. Yeah? Thank you so much, Galaboha. So I hope I didn't go over time because I was paying no attention.
Thanks. Okay, was this working? No.
What?
The screen here.
The screen was not working. Okay. That's why I kept looking up.
I assume so. Okay. Our next speaker is Sakile Ndlovu, who's an economist at TIPS and will present the findings of the paper. Thanks.
Good after morning. My name is Sakile, and I've been working on this project with the TIPS SA Vax team. So I'm here to present on the localizing vaccine, or assessing the feasibility of localizing vaccine manufacturing in South Africa. So I think what Niva's presentation has done is sort of like set the tone on how we look at the pharmaceutical landscape as one filled a lot of potential, establish fill and finish manufacturing, world class at that, but still beset by structural fragilities and risks. And I think my presentation looks to sort of like underscore that tension also, because at the end of the day, the policy tension between industrialization or industrial deepening aspirations, as well as the health policy imperative, which is supplying affordable medicines and accessible medicines. Next, please. So in terms of vaccines, so let me start with the structural problem, and we hope everything is going to flow from there. The economics of setting up a vaccine manufacturing plant are quite challenging. Vaccine manufacturing, drug substance manufacturing, that's end-to-end, front-loaded with fixed cost, facilities, equipment, transfer agreement, quality assurance staff. And at the low end of the investment range, those fixed costs can account for about 70% of cost per dose before a single vial reaches obviously a patient. And obviously these are projections made from a study that was largely focused on the United States of America. One example given that study is that a 25-year vaccine manufacturing plant producing 3 vaccines can account for cost of upwards of $1.4 billion US. So you can convert that in South African rands. So the costs that are obviously important, facilities and equipment in the hundreds and millions upfront, quality assurance staffing, which is very important for vaccine manufacturing, because a skilled operator in a vaccine manufacturing plant is the difference between a contaminated batch and a safe batch. So you need skilled operators. And that's before you even consider technology transfer fees, which can take the form of lump sums or per dose royalties, or even both. So the implication is very straightforward. The only way to bring price per dose down is to produce at very large scale. So for premium vaccine products, so these are vaccines that are being produced for high-income countries. The minimum scale is at around 10 million doses. And then for mass market vaccines, which are produced for low-income countries, you need about 50 million doses to even consider competing on a cost per dose front. Now, obviously, for Africa, we are trying to enter the supply chain, the value chain of vaccine manufacturing, also prefaced on obviously the AU's clarion call of Africa must be able to produce its vaccines, 60% of its vaccines by 2040. Theoretically, the African population provides a source of demand, aggregated demand, but the political economy of those countries or the landscape in Africa is a bit complicated, because you have to split them across 50 nations, and then you have to deal with different health ministries, procurement systems, national treasuries in those countries, and obviously regulatory authority. And that becomes a bit of a conundrum if you want to achieve purchasing consistency for a single continental supplier. That requires demand certainty. And what obviously also come out is that most of these projects have mostly been funded by overseas agencies and not African government themselves, because their fiscals are a bit constrained. And if we zoom into South Africa's domestic market, our market is just too small, especially considering that most of citizens are dependent on public health in this country. So drug substance manufacturing obviously cannot be justified at this point, especially also considering the fact that we do not participate, or Gavi, which procures vaccines for low-income countries and distributes them via UNICEF. We do not qualify for that because we're considered an upper middle income country. So we must pay for ourselves essentially from the fiscus. So we pay a much higher price per dose than low-income countries. And our market is too small. And there are issues with new entrants. You must be able to produce at scale before you even win a tender. So that means you absorb all the commercial risk upfront without even being sure that you're going to get a buyer. So the Serum Institute, which is the largest vaccine manufacturer in the world, took 22 years to produce its 3 human vaccines. That just shows you that it's quite a challenging and monumental task. And beyond the capital risk, there's also the human capital challenge. As I've mentioned, skill is especially important in vaccine manufacturing. You need graduates to already have about 2 or 3 years of experience at PhD level. That's what also the literature tells us. So you need skilled workers. And you have to also consider the market that you are entering. So there are already 19 suppliers competing for Gavi-affiliated country market. African countries represent 22% of all vaccines, but just 5% of value. This is the most price-compressed segment of the vaccine market in the world. So a new producer entering that space has no time to be an infant. The learning curve is a bit limited. Next slide, please. Thank you. So against the seemingly very bleak picture that I've presented, so where does South Africa currently stand? So there are 2 main initiatives that are looking to advance vaccine production by moving upstream from fill and finish to end-to-end manufacturing. BioVac is working with the traditional vaccine to produce or manufacture oral cholera vaccine. And then Afrigen is developing the novel mRNA-based vaccines for HIV and malaria. Both are very significant advances and obviously underscore the industrial policy and industrial deepening ambition South Africa has. However, both of these projects that I've mentioned, they are heavily reliant on donor funding. And this is a structural feature of the society, of this sector rather. You need to have donor funding to subsidize you because cost per dose is very sensitive to volume. So to get to scale, you need a lot of funding. It's a lot of trial and error. So foreign donors, obviously, especially through Gavi and their African Vaccine Manufacturing Accelerator, are one of the donors that are anxious for South Africa to be able to produce vaccines for not only locally, but continentally. And they're providing incentives on that front for South Africa to produce drug substance manufacturing. So just to state, the oral cholera vaccine, which I'll cover in the next slide, is obviously a bit different from other vaccines in that it's probably the one project that is going to be, or that is meant to be end-to-end manufacturing so made in Africa, produced in Africa, and then obviously dispersed in other countries. Whereas these other vaccine products or projects are still fill and finish. So basically, what we end up having is that to undertake this project, you have to consider there's high fixed cost, and you need to reach very large volumes before you can match the price offered by the established producers in India or South Korea. And again, South Africa's domestic market is just not big enough, particularly for a disease like cholera. So what do we have in practice is a BioVac producing the OCV almost entirely for the export market, with benefit to South Africa potentially limited to Forex, foreign exchange earnings, and some potential technology spillovers. And Afrigen's mRNA work which is very impressive, but has been mostly been dependent on US funding. Even the staff initially was from the US. And you then subject a project like that to a leader somewhere out there who's very erratic and chose to pull funding for low-income countries or countries in the global south. So that just shows you these initiatives are very subject to geopolitical shifts and obviously donor priorities. Next slide, please. So we had focused on the OCV case study because it provided a real world case study for us to look into. It gave us a concrete picture of what viability could look like in practice. And it's probably worth spending some time on it because it illustrates both the opportunity that is there, but also the fragilities that exist. So BioVac signed their transfer agreement with the International Vaccine Institute back in 2022. And the first clinical trial batches as of last year, I believe that went through and was a success. There's a target for a SAPRA approval next year because you need that to be able to supply via UNICEF. And they're also expecting WHO, World Health Organization pre-qualification for UNICEF tender eligibility. Again, you need that before you become a supplier. So the market opportunity is real. Africa accounts for 89% of cholera deaths. This could be potentially outdated numbers because we looked at a longer period of time. So updated numbers, the cholera outbreak report reports that of the 614,000 cases of cholera reported last year, between January last year and December last year, Africa accounted for about 40%, with the East Mediterranean region accounting for about 60%. And then there were cholera death cases that were reported were about 7,500. Now, this is where the difference is. Of the 7,500 death cases, Africa accounted for 70% of those. Cholera obviously is a disease, an outbreak-related disease that is obviously suffered in countries that have faced conflict, natural events, and mass displacement. That's why of the 22 cases that were reported, mostly were in the DRC. And globally, there's a projection that there might be 1.5 billion doses needed between 2020 and 2029. That's against a vaccine manufacturing capacity of only 50 million doses. Gavi's African Vaccine Manufacturing Accelerator offers up to $250 million incentives per manufacturer, especially if you are undertaking drug substance manufacturing, which is one of the subsidies that BioVac's OCV case has received and will be using. But let's look at the funding structure. So phase one was Wellcome and Trustgate's funding of about 120 million rands. And then there was an IFC International Finance Corporation loan of about $7 million at the time. And I just learned this week that in April 2026, this year, the International Finance Corporation and the European Investment Bank Group and the European Commission announced a major financing package of 20 million US dollar senior loan and a 75 million euros quasi-equity investment from EIB. So when you combine the loans, the funding, and convert them in rands, obviously, BioVac is about to attain or will attain over the course of the project about 1.8 billion rands. So that is significant. And it began, and obviously it sort of like provides support for the project when you consider the facility and equipment costs that were covered earlier on. But here's what I want to sit you with. Every rand of that funding comes from foreign donors. The South African government bears none of that cost. So that is good news, obviously, for the fiscus, but it also means there's no contingency plan if the support is withdrawn or reduced. There's also the critical pricing point. Without guaranteed demand, BioVac risks underutilization of its new facilities because you have to be within that UNICEF benchmark of $1.65 and $1.88. So importantly, BioVac will not, which is the most important, even if BioVac obviously is competitive, it will not capture the entire market in Africa. UNICEF deliberately maintains supplier diversity. BioVac must first demonstrate capacity. So if it's 40 million doses annually, BioVac could not capture that entire market. Again, this is an industrialization initiative, not a health security initiative, especially since cholera is not present in South Africa. The benefits of it are a bit indirect, but potentially there's technological capacity, skills, employment, and foreign exchange. Next slide, please. So who bears the risks? This is obviously crucial to the study. And Saul is saying I've taken enough time. So the NDOH faces the sharpest immediate trade-off. It wants to support local manufacturing, but is legally bound by the PFMA. It cannot absorb a price premium. National Treasury, obviously, if donor funding is abruptly withdrawn, has to fill that gap. For local producers, they are heavily investing given the high upfront cost. And obviously for regional countries who are the beneficiary, the risk is that the cost premium of African vaccines still exceeds what constrained health budgets can absorb from their countries. Next slide, please. So we must be explicit basically about the objective of end-to-end production. Under what conditions can it improve access to new vaccines in South Africa? From our study, the main barrier to vaccines in South Africa is low incomes and constrained public health budget. And local production doesn't necessarily solve that. We also need to be deliberate about a strategy of capturing technological spillover. Next slides, please, which should be the last. These are the strategic questions we'd like to leave the audience with to just think over, considering the measures that Niva presented. So what are the costs and benefits on focusing on drug substance manufacturing instead of just supporting fill and finish in South Africa? And how do we manage the contradiction between promoting pharmaceutical with high fixed cost and meeting the health imperative of providing accessible medicines? So in practical terms, how do we leverage the NDOH tender system to support local manufacturing without creating unrealistic expectations? And how can we better manage donor funding? Last slide. Thank you very much.
Thanks very much, Sakile. Our next presentation is also looking at vaccine-related issues, and it's going to be Annie Parsons, who's joining us online to talk about the future vaccine financing considerations. Annie Parsons is a researcher at TIPS and has joined us specifically for this project, and her work focuses on health systems and is also working with the NDOH on some of the thinking around costing of these things. Sorry, Annie, over to you to talk about vaccines. Sorry.
Thanks, Paul. So this last presentation, it's a slight pivot in that it's building on the work done to look at what, on a practical basis, the health department needs to consider in getting vaccines funded in South Africa. So it's broadly tying back into the question of what are the cost drivers and for building local manufacturing capacity. Okay, so next slide, please. The background to this is that the WHO organization has moved in the last couple of years to recommending that countries adopt a life course approach to vaccines as part of its Immunization Agenda 2030, which includes adults depending on age and illness. And really the question that we've been looking at is, given the constrained fiscal environment in which we're in, what does the department need to consider in putting forward a case to National Treasury to fund future vaccines? Our overall sort of the landscape of health and vaccines in South Africa is that certainly in terms of the funding available, we've always had very highly constrained funding. So we've got entrenched patterns of insufficient and inefficient funding. As most people know, most provinces start the year in the red. So they automatically have up to a quarter of what they should be getting in the new year going towards paying for things from the previous year. And in part, this is also because of our sort of national structure of funding, which was already with the national debt equal to 43% of GDP in April 1994. We've, however, had massive achievements in terms of health, key health indicators, our maternal and our infant mortality, with some of that actually being with vaccine preventable illnesses. And people often say that vaccines are a bit like the Secret Service. You don't know when they're working because nothing happens. Which is what you want. And we've seen that in terms of vaccines. I put at the bottom just sort of what's happened in terms of how our vaccine schedule has expanded over the years. To give you an idea of scale, back in 2019, when we introduced the pneumococcal conjunct virus vaccine, the PCV at that stage, PCV7, about 5 out of every 100,000 kids in South Africa would get meningitis or pneumonia related to that virus. And a third of cases were often fatal. Within 3 years, our cases had reduced by 81% because of this vaccine. So we know that vaccines work really well, but the problem is that, as Sakila has just talked about, we also know that they are not cheap. David had mentioned in the comments that, for example, South Africa actually did used to produce its own vaccines 30 years ago, but with the opening up after apartheid, these companies were basically unable to keep up with the regulatory and technical demands of the global market for vaccines in particular, and to meet their prices for the reasons that Eva went into. So we've become, as has been discussed, an import-orientated market for it. Next slide, please. This is to really give you an idea of the vaccine funding landscape at the moment in South Africa. On the right is a breakdown of how much gets spent by provinces from 2004. And it's broken into basically saying how much is spent on ARVs and how much is spent on EPIs and how much is spent, and the remainder that is spent on everything. This is obviously an average. Overall, our public sector expenditure on pharmaceuticals is actually highly efficient. It's only 8% of overall costs. As Eva mentioned, in the private sector by volume, it's much bigger. It's probably about 25% of costs in the private sector go on pharmaceutical spendings. And our average of about 400 rands over the last decade for pharmaceuticals spent by provinces per person. Obviously, it covers the huge range within it. The EPI, the Expanded Immunization Program, which is the childhood vaccination program, basically 71% of the costs of that are in the first year. So if you look at this breakdown and you look at the EPI expenditure, it has a lot to do with the population density and makeup for provinces as well. Next slide, please. But as said, we are operating in a highly constrained environment. So one of the key questions is determining a product's relative value for money and therefore its affordability. So in this, to this end, the National Department of Health plays a critical role here because it determines what vaccines are required and also negotiates the transfer tenders, with the provinces then determining how much they're buying and spending, et cetera, et cetera. And typically there are 3 ways in which costing new pharmaceutical products is generally done. The first is to use the lowest or the average of the lowest prices for an existing product if you've got many different versions. So generics and biosimilars, generally with vaccines, we don't tend to have that because of the nature of the market. So in that case, often South Africa will look at the reference price paid by a comparable country for a vaccine, a new vaccine, or it would look at what the cost is straight from the producer, particularly when there's only one producer. Because, as Sakila said, we don't qualify for Gavi. Instead, what we typically do is we look to the Pan-American Health Organization to look at what costs they have for the South American region, which is primarily upper middle income countries, which is what we are classified as. But that obviously has its own problems. So the third way is to start thinking about it in terms of, okay, how do we determine the value for money or the cost effectiveness of something, weighing the cost against the relative effect of the new product against either the existing product or the standard of care. And in South Africa, that is part of the ongoing process to have the health technology assessment process be part of how we generally structure our healthcare financing and systems, which is also part of the NHI. We have the 2022 HTA guidelines at the moment, which are used, for example, by the Essential Medicines Unit, which really talks about two key issues in determining what we should be looking at as our reference price or price point. The first is, as I said, the cost effectiveness. But the problem is that establishing your cost effectiveness, that number ends up having very little value if you don't have a threshold at which you can measure it against. And in this case, we're talking about generally the price that we put on keeping someone healthy for 1 year of life. So in South Africa, there are many, and this is a contentious issue, is how you do it. But in South Africa, one of the ways that is recommended is to come up with your own cost effectiveness threshold based on the supply side indicators, basically, in terms of how the department, what spending generally goes into healthcare services. And we actually have a study for South Africa, which was published in 2020, uses 2015 figures, and that essentially says that anything that is cost effective in terms of disability averted life years is cost effective if it's less than 38,500 rands a year. Now, the problem is, as I'm sure you're thinking, well, that's great, but how does that actually work out in terms of our budget? If we're looking at an average of 400 rands per person per year by provinces, and even the EPI cost is only about 2,700 rands a year for under a 1 year old. So there's also the question here of whether cost effectiveness is what we need to look at, or whether we need to start asking at what point there are cost savings to the department, in that putting in place a new vaccine, for example, would lead to cost savings, which was actually the case with the PCV7 study, or whether there are cost reductions, which means you see immediate savings in terms of, for example, the number of hospitalizations within the first year. Once you have that sort of reference price, then you can start asking, well, how much do we actually need to budget for? And that's where you get a budget impact analysis. And both of these are key for the National Treasury in terms of determining whether it's able to afford this against the broader consensus. However, even when you have this all together, next slide, please. The problem is where you're going to get the money. Now, ideally, we'd like to say our GDP growth is such and our repayment on the debt is such that actually there's enough additional money coming in that we can just allocate it to health. However, as we are all aware, that is not feasible in the current economic environment, and National Treasury since last year has been asking departments to look at efficiency savings in their budget. Within the health sector, the next option is to look at what we could do under NHI, which in theory would be reducing your existing spending from the private sector and reallocating it within the public sector. That would also increase the purchasing power for the government because we'd have greater market power. However, we don't have clarity on, firstly, the timeline for the NHI in terms of this. And also, without knowing how this would work, we do face risk. For example, if it is not correctly structured, we do face the risk that private capital could drive the prices that the public sector then has to pay, which is likely to make healthcare services more expensive and increase inequity. There's also the question of whether with vaccines, the government is able to negotiate lower vaccine prices anyway, given that there is a high consolidation within the market of products and producers. The third option, which is also sort of within the health sector, is to look at using something like the sugar tax. So an existing pot of money that, and this is the health promotion levy for those who, the sugar tax is the colloquial name, an existing pot of money that is intended for promoting health outcomes and currently goes straight back into the national revenue. And it's around about just over 2 billion rands a year. It's been in place since 2018, and that's sort of the average of what it's been bringing in. However, while 2 billion looks like a lot, when we start talking about vaccines, it becomes problematic. So for example, if you have a vaccine that is about 250 rams, which is about midway for vaccines per dose, and you're only targeting people over the age of 65, you're probably looking at a cost of about 1.5 billion rands a year. So that would mean for one vaccine, we're already using up that entire pot. It's also that the sugar tax is effectively a regressive tax because typically lower income groups, because of the nature of our food environment, typically spend more on high sugar food and drink. So there's also the question of the broader ethical and equity issues. Another way is to look for donor funding. So this in practice looks fantastic because it's not about whether our GDP is growing. We're not looking at budget allocations in the short term. And historically, South Africa has seen very high levels of funding. The PEPFAR funding for HIV and TB reached up to over 6 billion rands a year. Except, of course, as we saw with PEPFAR last year, donors can cut their funding at any point. So there is that inherent risk that, as Niva was pointing out, we would have to think about what the government is willing to take on. There's also an expectation with donor funding that it will be time limited. So it can't just be implemented without the government looking at how they can look at longer term financing. And the last way is to adopt a reserve financing strategy for vaccines in particular. So this is something that's usually recommended for, in fact, pandemic financing. For example, should we have another COVID-like emergency, it would mean that we would have a specific budget for addressing that. It's largely what our disaster relief fund does at the moment, but it would be specific in this case for vaccines. And that would be a bridging finance, while as with donor funding, you would look at the longer term strategies. Bearing all this in mind, next slide, please. What we are basically looking at, working with the health department in looking at how they could finance adult vaccinations in the longer term, is to really start in this current fiscal environment, and that is an important consideration, to look at products where we actually do have cost savings or cost reductions. So we know that we are going to see savings either in the very immediate term or the short term, which we can then feed back and then we can reallocate within budgets. This would require, and this would also take account of things like discounting, so that we know that we are what the shorter term achievements are. And then once we've done that, to figure out what would be the initial once-off investment you need to get over that initial spend that you need. Departments of health are not like factories. In that you can't just shut down a mode of production and then restart it when you've changed everything. At any given time, the majority of resources are always going to be committed. And it's about basically people's lives. So we have a very thin margin to work with. And what effectively we're doing is we're trying to cost out what we would need in order to give ourselves a bigger margin in which to make change that can then feed back into the regulatory system. And then, of course, we have to find those new additional revenue streams. So, for example, the one I've given here is what costs can be carried by the sugar tax. And really, what this comes down to is, and I've just put this quote here because I think for me this exemplifies the issues here. And this is actually from an epidemiologist. But effectively, the costs of change are mostly temporary, but we always have to pay them now. And the benefits are always deferred. So we always have to find a way to get to the point when we realize the benefits. And I will hand back to Saul at this point. Thank you.
Thank you very much, Annie. We've now got two discussants. We'll take the first one, who is Paul Miller, who's the CEO of CIPLA Africa, and he'll share his comments and insights on the presentations and the issues that have been raised. Paul, over to you. Paul is joining us online.
Thanks very much. I'll try and keep my comments fairly restricted, and first begin by just thanking everyone who has presented so far. I think it's been a very insightful presentation. I want to add a nuance to the conversation which maybe hasn't been considered as far as yet. I do think procurement, as it pertains to the government, is critical in terms of driving local manufacturing. And we do know there are significant challenges in that model as it exists today. We know that by nature, tenders tend to be at a lower price point. We've spoken about the challenges around implementation and monitoring those that claim to be local versus those that actually go ahead and import, despite the fact they've claimed local production. And how do you make sure that local manufacturers stay within the price ranges that have been proposed by the government? So I think if your definition of procurement is limited just to the public sector, I think you're never going to get to a scaled model of local manufacturing. I think it's almost important to find preferential procurement in the private sector. And I think the private sector is where you get the scale. And the earlier presenter spoke about almost 4/5 of the value sitting in the private sector and the volume as well. So if you leave the private sector to choose to localize, the chances are good they're not going to do it because they have large scale facilities sitting elsewhere in the world where they can actually procure from. Now, in order to do that, there are some very good examples up in North Africa. We look at models like Algeria, Morocco, where the government has put in very specific legislation and preferential procurement for the private sector, where more than 80% of all product that is consumed in the private sector in Algeria is locally manufactured. And how they've achieved this is very simple. If you are approved and you're locally manufacturing, no one can import a product into that country so long as there's a local manufacturer providing sufficient scale and volume. They've also built things like regulatory timelines, which is a big restraint on manufacturing locally. They've ensured also that regulatory gets a 6-month approval for local production versus an importer, which we're sitting close to 3 to 5 years. So there's not only are there regulatory enablers, there's also active engagement by the government to block the importers when there's a local. And you can understand the logic of that. If you've got 30 manufacturers all chasing down one small molecule, it gets fragmented, it's not scalable. If someone is constantly importing, again, that really dissuades local manufacturing. And so they've put incentives in place, they've put tax incentives in place, they've put zones in place. But ultimately, it's led to a very successful model that I think we should be thinking about in South Africa. Now, I'm talking as a CEO of CIPLA, I'm talking as a company that has more than 40 plus facilities in India. To be honest with you, more than 68% of our product that we need locally is produced locally. And I think it's time that we start putting in the right legislation and the right protection for local manufacturing, not just in the public sector, but also in the private sector, where I believe that's where the opportunity sits in terms of scale and sustainability. It does not have to be financed by the government. It does not have to get preferential pricing. The market dynamics will still determine the price points, but what the government can do is put sufficient legislation in place to ban importation on products that are produced locally and have sufficient scale to do that. And I believe that those companies that are producing locally will get sufficient volumes to protect them in competing versus other manufacturers, because the numbers will be few. I do believe also the public sector is critical. It always forms the basis of high volume, but I do think we need to think very carefully on two very critical dynamics. One is, what do we do about ensuring those who claim local manufacturing do actually produce locally? And what controls can we put on importation at the borders? And secondly, price points. Price points shouldn't always be at a premium for the local producer, but they should be allowed to negotiate. And there are different tender mechanisms that are used elsewhere, where the winning tender then is offered to all the local producers. And if they want to match the price, they can come in with the sufficient committed volumes. So these are just two incremental thoughts that I just wanted to put in here. I think in terms of de-risking COVID-like scenarios, I think it's very difficult, given the fact that under those situations, most of our products we produce locally, majority of the API is imported. And whenever there's a block, which happened during COVID, the API also gets constrained. So it doesn't matter if you have a local facility, if you don't have API capability, you're still going to struggle to deal with the COVID scenario. And that's something we need to think about. How do we de-risk the API component? Because fill and finish does not de-risk the country from any risk. So just some quick reflections. I hope that's helpful.
Thank you very much, Paul. Our next discussant is Marion Schonfeld, who's at the National Department of Health and is a senior pharmaceutical policy specialist. Thanks.
Okay, thanks. So a few thoughts from our side. I think it has been well described that the real issue is that the business of the Department of Health is providing health services. That is our business. And yes, we are the procurer of the products that we want to produce locally, but we have to remember that our core business is to ensure that essential health services are provided to everybody that needs it, as it's written in our Constitution. So that puts us in a predicament. Obviously, if we had an unlimited budget, what we pay for medicine, as long as it's cost effective and as long as the medicine is working, is not an issue. But the problem is, as long as we have limited budgets available, we are always placed in the position where we have to decide between, are we providing health services or how do we try to stretch the budget that we have available, which keeps shrinking every year, as we know, which is contributing to the problem where the provinces are in fact not keeping up to date, because we are always falling behind, because health services are essential health services, and because everybody knows that health services are essential health services, we often end up spending more money than we have available at any given time. And as Annie has indicated, that then results in us with the new budget paying off last year's money that we owe on our pharmaceutical items, and then this year creating a new problem that in fact we do have limited resources available. So the Department of Health definitely supports local manufacturing, and if you read our procurement or our special requirements conditions of contract, it is clearly indicated that we want to provide preference to local manufacturers. But obviously, there is no unlimited budget to do that. It has to be within the means, and it has to be economically viable to the departments to ensure that we can provide our essential health services, which is our core responsibility. I think there has been really good ideas on how we can improve or what we can change within our system. There has been a lot of talk about, ring fencing pharmaceutical budgets as a way to ensure that sufficient money is available so that we can, in fact, have budget available to support things like local manufacturing. But unfortunately, as I agree, to ensure local manufacturing, it cannot be limited and it cannot be the core responsibility of the National Department of Health. That is definitely a responsibility that should be shared between different departments, whether that includes National Treasury, Department of Science and Innovation, and Department of Trade and Industry. So my initial thoughts is definitely that we want to support local manufacturing, and from our special requirements and conditions of contract, it is clear that we want to support it. Yes, I agree, we don't actually give specific points to local manufacturing like Annie has referred to, but a lot of the way that we do our procurement is aligned with our procurement regulations that we have available, and there are some limitations. I think that Paul tried to highlight that something like designation is something that we could consider, but for designation to happen, we would have to have the available capacity within our country that it does not become a supply risk to ourselves. For instance, if we said that we will not be importing any amoxicillin tablets, then it would have to mean that within South Africa, we have the required capacity to produce all the amoxicillin tablets that we would require for ourselves, and hopefully to export, because I think that none of the local manufacturers would be sustainable if we don't have an export market. And I do think that there's an opportunity to look at pool procurement mechanisms and exporting to the region as well as something to consider to ensure that local manufacturing is sustainable. But from the department side, our core business is providing health services. It has to be affordable both to the country and to the citizens that is funding our health services. And with the growing economic burdens on all of our households, we expect our population that needs these health services from the public sector to increase rather than to decrease over time, especially as we move towards NHI. So it has to be affordable to us. For it to be affordable to the department, there has to be collaboration between all the different departments to ensure that local manufacturing is sustainable over time. And that's definitely something that needs to be funded through either donor funding as indicated, but there has to be a backup to donor funding within the country as well. And we have to ensure that we are exporting the products that we are producing locally. Thanks.
Thanks very much, Marion. We've now got a whole lot of questions and comments online. So I'm going to just ask the questions that are online, and then if people have questions or comments in the room, I'm going to ask you to come up just to ask your question. So online we have Stephen, who asks, how does the CSIR fit into the model for developing processes to promote local manufacture of pharmaceuticals, and can they assist with pilot and scale-up activities? Ronald asks, how would the localization of the pharmaceutical industry incorporate indigenous knowledge in API development? And how does that align with the bioeconomy strategy of the country? We then have from Cara, who asks, has a comment first around the importance of this discussion and the need for a whole of government policy. And then how does the pharmaceutical manufacturing roadmap align with the vaccine innovation strategy? And then Karabo asks, how would the current inter-Africa tensions that have emerged because of the xenophobia in South Africa impact on our exports to other African countries and scaling up? And that's the questions online. I don't know if we want to deal with, I don't know if all of those can be dealt with. We may not have done some of that work, but I'll ask the presenters and even the discussants if they have views on those issues. And then we'll go to questions in the room.
I mean, most of those we can't actually answer because we just didn't look at them. So they're very interesting, and we will think about them going forward. The one thing I would say about the thing about the modeling was that we only looked at the impacts on value added and employment as multipliers from increased in sales from various and increased localization. I mean, Mandani's there if he wants to speak to it, but I think the important thing is other impacts, like for instance, security of supply, we didn't look at. We did look quite in depth at what do we think are the main causes of insecurity of supply. And I'm just going to repeat this. I think we need to be careful about this idea that if we produce things locally, we will have security of supply. We produced large amounts of vaccine for COVID-19 locally, and none of it was sold locally. And you can argue how much was due to technology transfer issues, but the restrictions, but the fact is, if we could have paid for it, I'm fairly sure we could have got more of it. So I think we need to be very careful about, to what extent is security supply dependent on physical production locally, and to what extent is it based on affordability and by extension competitiveness. And I think the assumption that because we produce something locally, it will be locally available, we have shown repeatedly in this industry, is just not the case. And I think we need to be much more careful about defining what do we mean by security of supply and what ensures security of supply when you have a limited budget. The one other point I wanted to make was about pooled procurement. I see there, sorry, I can't see all the questions, but some of the questions came up. I think, pooled procurement is important, but I think we should look at all the factors, like all the NTBs in particular that prevent sale to the rest of Africa, because some of it is also about how medicines are registered, how they're regulated, even what languages we have on the packaging, that kind of thing. And if we could simplify, we've been saying this for at least 15 years, if we could simplify some of those things and come up with more common regulatory frameworks, which I think, for instance, through the African Medical Association, that might actually be easier to do than trying to get pooled procurement, which requires treasuries to get involved in and donors. And as we all know, they have some, it's sometimes hard to get them all in one room.
Okay. Sakile, any comments on what was questions? No?
Not really. I don't think there was anything specific to the vaccine presentation, but also like Niva has alluded, some of the questions we're still engaging with them, and it's quite difficult right now to preempt what the likely conclusion will look like, given that there's ongoing conversation right now on how the pharmaceutical industry as a whole can be, obviously uplifted. So up until there's a conclusion of those discussions and there's an established pharmaceutical roadmap, then we can probably engage at length with those discussions.
Thanks. Marion, any views? Annie or Paul, do you have any comments on the questions that were raised?
My reflection, I just want to comment on the concept of export. I think, again, I'd be very cautious and cynical in that area. When you start to compete outside of South Africa and you start to look at export, you're now starting to open yourself up to large-scale global players that have facilities that are supported by big domestic markets. I'm thinking of companies like India, countries like China. These countries have large domestic markets which enable them to produce at scale, and pharmaceuticals is a high volume game. So if we're thinking that we're going to compete from South Africa as local manufacturers and going into exporting, be aware that you're going to come up against companies that are supported by big domestic markets. And they often see Africa as being a dumping ground for products at very low price points. The second consideration on exporting as well is that Africa is a continent of 50 plus countries, all requiring their own regulatory pathways, which brings significant complexity to the exporter, where they have to have multiple approvals across multiple countries, 50 plus. And on top of that as well, those countries are small in nature, particularly if you're looking in East Africa, where the markets are probably only about $600-700 million in size. You're not going to get the volume offtake, and each of those countries will require specific packaging, specific regulatory priorities, which will bring complexity to your local manufacturing. So hence why I keep going back to this idea that you need to strengthen local for local, because there, with sufficient protection, regulatory enforcement, as well as legislation, you can achieve those kind of scales and reduce the complexity. South Africa is one of the biggest pharmaceutical markets in the continent, just sitting shy of $4 billion US, not too far from what we see in Algeria or even in Egypt.
The only comments that I would add, which is not actually on pools, but to the question of considering, for example, indigenous knowledge, etc. We didn't cover that, as Neva said, but it is evident from the study in the paper that one of our strengths is actually already the ability to come up with novel products. So thinking through ways of strengthening that is a pragmatic way of looking at building out the end-to-end process from what we can already do. Yeah, over.
So we have another question from Portia, who raises the issue of, she first makes a comment on whether there needs to be that there does need to be alignment between procurement by the state and the private sector, so that designation is not just for state procurement. And then asks a question, pooled procurement on the continent can be premised on a pharmaceutical roadmap, a pharmaceutical partnership agreement with strategic partners, and give some examples. So I don't know if there's any comments, including from Swasti, on the issue of pooled procurement, particularly experiences we've seen in other countries, and also just what's happening with other African countries on getting that right to create the demand sufficient for local production. Swasti, or any of the other presenters?
I just want to talk very quickly about private procurement, because I think it is easy to say we should have local procurement, but the way you normally get local procurement in the private sector is through tariffs. And it seems quite difficult to imagine putting tariffs on medication. The other thing is that I think, and I stand to be corrected here by people who know more than me, but the private sector, because a disproportionate amount of private procurement is through medical savings accounts by individual households. So I think it would be quite hard to get to a few products that are common is more difficult than in the public sector, where you have scaled production of medications. And I think that's why people have seen the public sector as being more easy to control, even though it's actually got less resources than the private sector. So I think one would have to think through what are the mechanisms that would enable the government to say to the medical aids or to individuals who are buying medicine that we are going to limit what you purchase to local products, and how do we manage issues around price differential in that context? Because as we've seen with the NHI structure in general, there's huge pushback on that kind of regulation, even if it may be socially desirable in some cases.
I'll just add the comment, though, that I don't think putting tariffs in place is an optimal one, because someone's going to have to pay for that, and I think it's going to cost the health system even greater. I think my proposal that we're pushing was the Algerian model, where it's just very simple legislation. If you are a local manufacturer and you have scale and you have sufficient volumes available, then the government offers protection to you by blocking any more further importation. And there are already price mechanisms in place within South African structure. It's the Department of Health SEP, as well as the formularies that are held by the medical aids like Discovery, Momentum, as well as the corporates. So there are controls in place in terms of pricing. So I think there are existing models, and those Algerian models are working. 80% of all products that is consumed in Algeria is produced locally, and those are by large private pharmaceutical companies. And the interest is that you even see large corporations like AstraZeneca, GSK, Pfizer are producing in Algeria. We don't have that in South Africa. We don't have those nationals committing to the local market because they know they can fully import. So taking time just to reflect upon example at no cost to the government and no cost to the health system, but making sure there's actually better product, secure supply product, and localize it.
So I think that what Paul is kind of referring to is a type of designation where there's no competition for those products that are produced locally within those types of countries. The challenge with that would be that, one, you would then limit new entrants into the market. So you will actually make your pharmaceutical market, especially for those specific products, smaller. And then in the long term, increasing your risk to security of supply. Because obviously, if those products are not registered and companies are not interested in registering those products in our country, we won't have access to those. And then secondly, the other challenge that you would have with designation is in terms of costing. So what would you use as your reference pricing? Even if a product is protected, let's say that we agree that all measles vaccines, we will only procure locally produced measles vaccines. Still, what should we be willing to pay for those measles vaccines? What should the cost be because those costs would have to be determined, and it will still have to be paid by someone. So at the end of the day, that someone is likely to be the department. The moment I remove competition from an open tender process, what would be the incentive of the local manufacturers to produce that product at a price that is reasonable to the state, firstly? And secondly, how would we prevent collusive bidding where obviously the pricing at which they would place bids would be known to everybody because, there would be one or two applicants in the market that would be able to place tenders for those items. So we have to understand that even designation has its risks and has a cost that someone will have to pay, even if it's a good model to consider.
Yeah, I just think though that you need to differentiate between the public sector and the private sector. And my comments were reference to the private sector. I think the public sector has to work on a different mechanism. And I hear what you're saying in terms of protecting the state in terms of price. And I think you need competitive bid process. But there are ways to still incorporate local manufacturers at those price points.
So Saul, can I weigh in a little bit? Thank
Please
you.
do. Yeah.
So I think the designation discussion requires a bit more discussion, right? It's not as simple as we want to make it out to be. There are risks, but we need to carefully design the policy to ensure that we mitigate against the risk. There are obviously in the Act, the Procurement Act, there are special clauses that indicate how designation needs to be applied and having a minimum of 3 local manufacturers, etc., etc. I do think one of the things that Paul had mentioned earlier is that competitive bidding price, and perhaps using that as a reference price, where you allow local manufacturers to meet that. But at the moment there's no transparency around the prices of bidders, and Marianne, you guys can advise as to how that could be allowed or happen in the context of the existing legislation. I do think there may be merit in looking at the private sector, but again, cautiously, and maybe designing something or piloting something rather to see if it works or doesn't work, and perhaps not your day-to-day meds, looking at future priority products that are expensive, difficult to access, and where we give local manufacturers and close the market off for them for a little while, so that they establish themselves, and when they establish, then allow competition in at that point. So any instrument that we talk about has to be time bound and very specific, and yeah, we need to really look at what potential risks could come in. I do want to answer Portia. The thing is that the roadmap is now being escalated. It's now being driven or coordinated by the presidency. So I'm hoping that that gives us the gives us that that level of priority that it has been in discussions but has been missing in reality. And yeah, on the pool procurement, I think, except for what's happening now, there is broadly a commitment by by AU, Africa CDC, but the only real tangible commitment is on vaccines. And we need that to be broadened, but there are things that need to happen. And I think we're seeing now a lot of things that are coming, together a bit faster than they were in the last few years, especially around AMA. NAFDAC, the Nigerian Regulatory Authority, acceded to AMA in the last month. SAPRA, South Africa has been lagging, but I think there's movement now internally, and it has been escalated, so there will be a push from the presidency so it gets to cabinet quickly and it's ratified. But still with that, there are other challenges that need to be recognized because AMA doesn't have regulatory capacity. So they will rely on some of the more mature regulatory systems. Pool procurement, again, not quite as defined and clear as we need it to be. But in terms of in terms of the static pool procurement, one of the things that is being done is they are presenting a mechanism or mechanisms that could be considered. The intention is to pilot through SADC the procurement of lenacapavir, which I'm not sure if all of you know, it's the long-acting injectable, which is maybe a game changer, but there are other treatment regimens for treatment of HIV that are coming. But it's an injectable, long-acting, twice a year. We don't have a license. We are working together jointly. I think even preceding the roadmap, jointly as government and a number of partners, including development partners, working on getting a 7th license for this. And there is commitment by SADC that they would look at how this could be one of the first and priority products that is piloted for pool procurement on at least at the regional level. I saw some other questions, but I think we probably need another discussion on the roadmap when we are there, when we have something that's robust and costed and phased properly. Then we can answer some of the questions. Just the colleague from the CSR, yes, CSR is part of that interdepartmental committee, and there are things that we are considering for that the CSR could help in assisting companies locally diversify their product portfolios for local manufacture purposes. I'm going to leave it at that. Thank you.
Thanks very much, Swasti. I'm just going to ask each of our presenters and discussants to wrap up just with 1 minute final conclusions on the discussion. I'm going to start off with just in order of the presenters. If Neva, you've got any last comments for 1 minute. Thanks.
Yeah, I mean, I think that the discussion about the big strategy is important, but I would really be grateful if we could also start looking at some of these measures that I think everybody in the industries agrees are important, like, for instance, improving the supply chain capacity and in the departments of health, and improving the turnaround time at SAPRA and some of these things. Having said that, I do think that it's really important for the people who are interested in industrial policy and pharmaceuticals, not just to say, this is the kind of measure we want, but to be more clear about who's going to pay for it. Because it is genuinely, easy to say local procurement, but if there is any kind of additional cost, then you can't ask the departments of health to pay. Similarly, with the private sector, if you start saying to citizens, we are going to find a way to protect local supply, but the price will go up, I guarantee there will be massive political pushback. And so we need to be clear about who bears the cost of industrialization. There are infant industries. We need to support infant industries, but we need to make that a transparent and understandable decision and be able to say to people, this is why the benefits outweigh the costs, and this is how we will ensure that it doesn't impact on healthcare, because for most people, healthcare is kind of sacred.
And I think all these very innovative suggestions and the inputs that are being made obviously have to take place at a centralized interdepartmental platform, so they can be easily ventilated, so that there can be obviously a policy or a strategy that is going to be adopted, a national strategy that is going to be adopted, that is going to factor in all these trade-offs. Because right now it seems like there's a lot of discussions, but they're in silos. We want to industrially expand as a country. We want to enter the global value chain, but we still have these constraints in a country like South Africa that has a large pool of people who can't afford, like those who use private medication or private hospital plans. So that's important. And secondly, the economics of end-to-end manufacturing don't only benefit ambition, but they also benefit scale, huge amount of scale. That has to be backed by a financial mechanism. And obviously a financial mechanism has to be tied to this national strategy. That has to be led by a political principle, whether it be in the presidency or wherever. And I think once that is established, then this discussion can be held in a much more productive manner. Over.
Thanks. Yeah, and I would just finish up this bit by just saying that I think that what we've been discussing does re-emphasize the question of who pays, and that certainly for the public sector, the Department of Health faces enough issues in getting things paid for when we are able to access the lowest price from imports. That talking about localization really needs to cost out who is going to pay when it can't be the Department of Health. Over.
Thanks very much, Annie. Paul, your last comments?
Yeah, I just think we need to be quite deliberate here. I think if we're looking for incremental approaches, it's not going to get us where we need to be. If we are very serious about local manufacturing, particularly in health, I think we need to have a transformational mindset. Is very critical for me. One of the key issues that we hear as we continue to blur the roles of the public sector and the private sector. And I think the public procurement is important, but it's not designed to build industries, and it's designed to buy efficiently. And I think asking it to do both often leads to underperformance on both fronts. So I think the evidence for me from countries like Algeria and Morocco is quite clear that the private sector must become the engine of manufacturing. But it's only when the market is intentionally shaped. And I think this is where the government have got to rely upon procurement, not on procurement alone, but they have to ring fence, I think, these markets. They have to create incentives. They have to create actions and allow for clear business rationale. What I'm calling for is let's be not incremental, but let's be transformational, and let's understand and learn what other countries have done in the face of these challenges. We've seen it in China, we've seen it in India, we're now seeing it in North Africa, Algeria, Morocco, and they're getting the support from private sector. And I think we need to take a lesson out of their books.
Thanks. So I think that from our side at the department, I think that our core responsibility is to ensure we can provide affordable healthcare to all the citizens in South Africa that require that, just as is stated within the Constitution, but it has to be affordable. And while we support local manufacturing, and you can see that through our procurement processes that we are trying to implement with a clear preference provided for local manufacturing within our processes, it is important to understand that the cost associated with that has to be considered. It is also important to note that from the 51 billion rand worth of contracts that we have already awarded, or that is currently awarded to suppliers, more than 16 billion rand of that is going to local manufacturers or to manufacturers that have claimed that they are producing locally. So the commitment from the department is clear. But at the end of the day, we have to ensure that the services we are provide is quality health services that are affordable, both to the taxpayer and to each of these departments that participate in our state tenders. So we hope that the local manufacturing capacity grows sufficiently, where the economies of scale are in such a way beneficial to the companies, so that they can provide affordable products to us as a state, so that we can procure them. So we hope that the local manufacturing grows, whether that's private or public, and how it should be supported. We definitely support it. Thanks.
Thank you very much to all our presenters and for everyone joining online. Apologies, the load shedding, well, I don't know if it's load shedding, municipal outage has hit us, and our solar kicked in for most of the session, but not the last bit. So thank you everyone for joining us. Those that are in the room, if you've got questions for discussion, we can chat over lunch. We do have some food at the back and invite you to join us. To the participants who joined online, we had a very rich discussion, and I think there's still a lot more discussion we need to have on this issue. We hope that the research that we presented takes us forward. And as we've heard from Swasti, there's a lot of thinking that's happening right now in driving a roadmap around where we go to with the pharmaceutical industry, and building some of the capacity that we don't have, closing the gaps, and looking a lot stronger at the export market, so that we can expand the sector and to meet some of the security of supply requirements. We've also heard a lot of input on we have to be cost competitive in order to get this right, which comes with its own challenges. And there's a need for ongoing support and alignment between the public and the private sector. So thank you very much to everyone for joining us, and have a good afternoon. Thank you. Bye.